Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week summaries, which this week were brought to you by our authors Shannon Marcus, Ketan Patel, Kyle Rankin, Rebecca DeFabio, Samuel Rouleau, and Clay Smith. Okay, let's go straight to the second article. Titled Diagnostic Test Accuracy of CT for Open Globe Injury, a Systematic Review and Meta-Analysis of Overall Impression and Individual Imaging Signs, out of the journal Injury. All right, so after you had some kind of trauma to your patient, it's not uncommon that it's very difficult to do an eye exam. Your patient is altered and they're all swollen up around the edge of the eye. It's very difficult to see if there's actually been damage to the eye itself or just the structures that surround it. And so in a lot of these cases, of course, we're going to try to get a CT scan. But how good is a CT scan at assessing for an open globe injury? These are ophthalmologic emergencies and can often lead to blindness if they're not addressed very quickly. This paper was a systematic review and meta-analysis, a SIRMA, that found 8 studies, total over 800 patients with 339 confirmed open globe injuries, and wanted to look at how good a CT scan actually is at assessing for an open globe injury. What they found was that the pooled sensitivity of CT scan for an open globe, it wasn't that good, 75%, and the specificity was 94%. So that's not terrible from the specificity side of things, but the sensitivity, that leaves a lot to be desired. This results in a positive likelihood ratio of 6.4, again, pretty good. So if it's a positive CT, I'd say, run with it, but a negative likelihood ratio of just 0.67. So a negative scan, it can give you a little bit of confidence, but it shouldn't make you very confident at all. The most common finding of an open globe injury was a change in the anterior chamber depth. This on its own was 94% specific, but only 47% sensitive. Other things that you can use to assess if you think there might be an open globe would be things like a change in the globe contour, vitreous hemorrhage, lens abnormalities, or intraocular air. Which obviously, if you've got air in there and you're not post-surgical or something, that's going to be weird. I think this is a great article. I think this is good to know. When I do see traumas, I'm never really sure how good the CT is. So now I know that if I don't see an open globe on my CT, but I highly suspect it clinically, or there's a really good reason for it, I'm still calling ophthalmology in there quickly to get a proper exam on these patients. And also, if the scan is positive, then I'm going to put my money on it. This is a real emergency for that person's eye. In a spoonful, the CT scan is pretty specific, but not that sensitive for open globe injuries. So if your CT is okay, but your suspicion is high, call ophthalmology. If the scan is positive, they probably have it. Okay, then let's skip to the 5th article, titled Association Between Non-Invasive Positive Pressure Ventilation Use and Clinical Outcomes During a Severe Asthma Exacerbation, a Cohort Study, out of the Journal of Critical Care Medicine. Now, I think it's become really quite common practice that for pretty much any respiratory distress / failure, that we consider non-invasive ventilation with positive pressure before we go on to intubations. Now, sometimes, of course, you're not going to be able to stop at go before collecting $200. You're going to go straight for that intubation. But in most circumstances, if we can get away with it, then we'll just do non-invasive. This has been proven to be very effective in COPD exacerbations as well as for pulmonary edema. However, for other indications, the efficacy is not so clear. One of the common things that we use it for these days is for asthma. However, the data is really quite limited. This was a retrospective propensity-matched analysis of a statewide administrative database to look at many patients who had severe asthma. I'm talking over 250,000 adult patients and almost 100,000 pediatric patients. A lot of them were really very sick. And they showed some interesting things. There was actually about a 5-fold increase in how often we're using non-invasive ventilation from 2006 to 2018. It went up from 1.2% up to 7.4%. That's a really big difference. However, the rate at which we did intubations and the mortality rates over time overall, those were stable. So despite 5 times more use of non-invasive, we do not seem to be saving lives overall. However, when you cut the data a little bit differently with propensity score matching, we see that non-invasive ventilation was associated with a lower risk of intubation and mortality in adults. And it was associated with a lower risk of intubation but not mortality in pediatrics. These were all risk ratios of about or better than half. So the association is there. However, like I said, overall rates of mortality, despite 5 times higher use of this, are not better. So there's an association between the use of non-invasive ventilation and not needing to be intubated or dying. However, I guess if you can get away with non-invasive ventilation, then yeah, you're at lower risk of being intubated and of dying, of not dying, because if you can't be ventilated that way, then, maybe you're at higher risk. Maybe you're sicker and you're going to die. So this is really just an association. It's an interesting way to see the data. But if the overall mortality rates are not improving despite big increases in this treatment modality, then I don't think that it's really saving lives. It's probably convenient, and maybe we're preventing some people from needing intubation who might have otherwise needed intubation. Or at least we're making people more comfortable with not intubating someone who otherwise would have been intubated. But it's not clear, certainly not from this study, and there's not that much other great data that shows that it is actually saving lives. One thing they did not control for was the severity of the asthma attack. Now, of course, all of these were going to be severe asthma attacks, but, there's probably still some gradation in there somewhere, and it would have been nice to see something in this regard for something that we could control for. So in a spoonful, it's kind of a mixed picture. Non-invasive ventilation is being used more, but we can't definitely say that it's saving lives. I'd say continue to use it though, for sure. Okay, and that's all the articles from this week. So what did we learn? The second article was that CT scans do a pretty poor job of ruling out open globe injuries. However, when they're positive, they probably have an open globe. And then from the fifth article, non-invasive positive pressure ventilation is associated with, but likely not the cause for, decreased rates of intubation and mortality in asthma exacerbations. Okay, so if you're hearing this right now, then you are not a part of the members feed, so you missed 3 articles from this past week. What did you miss? Well, we did a review of cardiogenic shock, we did a review of cardiac arrests in athletes, and then we looked at the best way to stop a pelvic bleed. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.